Good evening, everybody. We are here today for evening, every Thursday, usual evening classes by our Chest Council of India. So, as we have a as everyone knows, the topic is a very huge topic. We will have to start as soon as possible so that we don't have much delay in the progression. So today we have a few esteemed faculty who I'll be introducing now. First, we have Dr. Him Parikh. He is practicing as associate professor at the SMCGH Medical College at Amreli, Gujarat. He is a state task force member of our national TB elimination program. He has 6 national publications till now, and he is a speaker at state and national conferences. Next, we have Tridib Chatterji, sir. Sir is a very senior pulmonologist. He has almost more than 30 years of experience in Mumbai itself. Sir is the founder and a past president of our Indian Association of Bronchology. Sir is a faculty at most national pulmonology conferences. And sir also will be dealing very much into our pulmonology topics today. Then we have our most important, renowned senior professor of pulmonology, who is known throughout India, Sir Vishnu Sharma, sir. Sir is the HOD of one of the best PG departments at AJ Institute of Medical Sciences in Mangaluru. He's an avid researcher and publications expert, while also being most loving teacher to his students. In Sir's free time, Sir is a reviewer for multiple journals like ERS, Breathe, our Indian Journal of Immunology and Respiratory Medicine, the Medical Journal of Dr. D.Y. Patil Vidyapeeth, Lung India, Pulmon, and even the Eurasian Journal of Pulmonology. So, and today, the most important introduction is of our gastro consultant. Sir, Dr. Abhinav Sharma, sir, is a director at the Department of Gastro at CK Birla Hospital at Jaipur. He has established the first GI physiology lab of the state in the department. After his MD, and along with his DM, he also did his Pediatric Gastroenterology, PDCC, from Sanjay Gandhi PG Institute. He has got multiple awards for best paper presentations in gastroenterology. He has lots of publications, and it's all present in major gastro journals. He's a senior faculty in gastro, so he's always busy with being faculty for national conferences, even up to organizing conferences. So very welcome, sir, Dr. Abhinav Sharma, sir. And so we'll be starting our meeting for today. And I think what I'll do is we'll start with Dr. Him Parikh, who will be covering on the interesting case version, he being a pulmonologist, the interesting cases that he has seen in his practice, where he has found that GI involvement is significant in the assessment of the patient, in the treatment of the patient, and even in the outcome of the treatment for the patient. So we'll be starting with Dr. Him Parikh, and then, so Him Parikh, we can shift over to you.
So good evening, everyone. Thank you so much, Tony sir, for that kind and wonderful introduction. And at the outset, I would like to thank CCI for giving me this wonderful opportunity and bringing out this unique topic in which I'll be discussing more on a case-based topic. So we'll start first with the case. She was 56-year female, housewife, comorbid only hypertension, presented to us with 2 years of dry cough without any other significant history. We work it out for ECG. It shows the changes of LVH. She was on telmisartan 40 mg HS. So this was the X-ray. You can see there is some hilar and mediastinal abnormality seen. So I'll come back to this X-ray later. And let me go to this topic, gut-lung axis, which refers to the reciprocal exchange of microorganisms and/or their metabolites and immunomodulatory signals between gut and lungs. So you can see I have put very simple diagram. The gut and lung are connected with microbiome, microbial metabolites, and through circulatory system, which is blood circulation, immune system, which is mostly through the lymphatics. And let me tell you this bedside version, that every patient that comes to our clinic invariably asks, sir, what to eat, what not to eat. They even come with their own theory that, sir, I have ate that, so my asthma worsen, my COPD worsen, my respiratory symptom worsen. So the gut-lung axis has been known to our patient since very long. So the gut-lung axis has pharyngolarynx common to both. The bacterial load is highest in intestine, lowest in the lower respiratory tract. And as you can see, the common phyla, the bacterioids and the firmicutes are common to both lower respiratory tract as well as GI tract. So how the gut-lung interaction occur? Mainly through the micro and macro aspiration. And it was evident by the BAL, which has been shown all gut microbiome bacteria. There is something known as gut-lung lymph axis, which is connected through gut to a lymph node. And you can see whenever there is a damage to that gut-lung lymph axis, the inflammatory mediators, like you can able to see on your laptop or mobile, interferon gamma, IL-6, TNF alpha are able to disturb the tight junctions and increase the epithelial permeability. From there, they go to the afferent. From there, they go to the lymph node. From there, efferent through thoracic duct, and then they come to the systemic circulation, from which they goes to the lung and to the CV system also. So GERD, we all know, regurgitation of the GI contents into the esophagus. Prevalence is as high as 20% in adult population. Symptoms we all know: heartburn, belching, epigastric pain, nausea, dysphagia, extraesophageal symptom, dry cough, chest pain. The endoscopic and histopathologically it is divided in three phenotypes: the NERD, erosive esophagitis, and Barrett's esophagus, out of which NERD is common. So what are the risk factor and the pathophysiological mechanism? This is also very known to us: chronic tobacco use, alcohol, smoking, lower socioeconomical class, various CTD like systemic sclerosis, various anticholinergic drugs, NSAIDs, caffeine. And what is the basic pathophysiology is impaired lower esophageal sphincter, which allows the GI contents to move upward, transient lower esophageal sphincter relaxation, hiatus hernia, defective esophageal peristalsis, and impaired esophageal defense against the gastric reflux. So what is the diagnosis and treatment? Radiographic studies can help, but it has limited role for detecting the abnormality. Esophagogastroduodenoscopy, which can diagnose erosive esophagitis, Barrett's esophagus, and so on. 24-hour ambulatory esophageal pH monitoring considered to be the gold standard, but is not available everywhere. It can diagnose pathological acid exposure, frequency of the exposure of reflux, and correlation between patient symptoms and the reflux events. Lifestyle modification start with the non-pharmacologically: weight reduction, diet modification, 3 hours time between sleep and meal. Medical treatments are, we all know, PPIs and H2 blockers, omeprazole, lansoprazole, ranitidine, famotidine. Surgical Nissen fundoplication, if not improved with the medical treatment. So this is a beautiful figure. I will take half minute or minute here. So all the up arrow shows the causative mechanism, how the stomach content from the lower esophageal come to the esophagus, from esophagus to upper esophageal sphincter to pharynx to glottis to airways, and then aspirated to the lung. So the causative up arrow I will read 3, 4. GERD, hiatus hernia, intra-abdominal pressure, gastroparesis, dysphagia, diminished consciousness, which are the causes that allowed the regurgitation from the stomach to esophagus to pharynx to the lung. And what are the protective mechanism? Cough reflex, epiglottis, vocal cord, mucociliary barrier are all the protective mechanism here. So how asthma, bronchiectasis, COPD related to the GERD? So in asthma, pepsin, which is considered to be a gastric enzyme, has been detected in bowel. Microaspiration is quite common. COPD patient, there is also 20% patient has been detected with pepsin in 1/3 of their sputum, and also in their exhale breath condense. The beautiful ECLIPSE study, you can go, it is in the European Respiratory Journal, showed that GERD is an independent phenotype for the frequent exacerbation. And how bronchiectasis is related, that we have found bile also in the bowel of cystic fibrosis patient. So these are the connected. In IPF, the study, various studies shows that it has odds ratio of 1.6%. In IPF, generally GERD usually remains silent. Heartburn prevalence also significantly lower in IPF GERD patient rather than GERD. As 24-hour manometry is not readily available, there is some questionnaire is there which has been validated by the trials, Hull airway reflux questionnaire, like our CAT score. And if the score is more than 40, it is significant. So this is how GERD and IPF connected to each other. Chronic reflux, microaspiration, alveolar inflammation, fibrotic modeling leads to IPF. IPF in turn fibrosis, lower elasticity, increased negative intrathoracic pressure, relaxation of LES and upper esophageal sphincter lead to microaspiration and goes to GERD. So this is how the patient keeps on from GERD to the IPF. Back to our case. So this is the CT. You can see this is the CT, and here you can see the air fluid level-like structure in the mediastinum. I think you will be able to see now. See more evidently. And what was it? It was the sliding hiatus hernia into the mediastinum, which was causing the cough. So this is second patient. So she was 27-year female on DRTB regimen, presented with nausea, vomiting, abdominal pain. Our usual diagnosis generally is that it should be gastritis or maybe hepatitis. So we checked LFT with prescribed PPIs, but she was not relieved. She was admitted. We did USG abdomen, showed prominent or subacute intestinal obstruction, but it was nothing like that. Injectable PPIs were also not working. So we did the upper GI scoping. And you can see the upper GI scopy, the pan gastritis is there. Along with it, there is rapid urease test positive for H. pylori. And this is also important. H. pylori is known to cause exacerbation in COPD, asthma, and even in TB patient, we should have high suspicious when on AKT and the gastritis is not relieved. So she was relieved when the H. pylori regimen is started. So this is last case. She was 58-year female, works in a bank, no comorbidity, presented with cough, with scant expectoration for 3 years, grade 2 dyspnea, no exposure, no addiction, and then bilateral lower zone CRAPS, SpO2 remain 94. These are the CTs and X-ray. You can see there are some opacity in lower zones. CT shows bilateral ground glass opacity, some cystic lesion, and then there are even subpleural fibrosis. Evaluated for CTD, autoimmune disorder, all normal. Bronch was done already on somewhere in other hospital. So we proceeded for thoracoscopic lung biopsy. And what does it shows that some vegetable foreign material also there, along with foreign body granulomatous reaction. So it was considered as aspiration pneumonia. So we again did the scopy, and there you can see there was a tracheoesophageal fistula present. So these are my take-home message. Gut-lung axis microbiome is important for treatment, connected through blood and lymph vessel. GERD remains silent, have high degree of suspicious, and GERD, pylori infection, hiatus hernia contribute to the exacerbation phenotype. Thank you so much.
So good evening, friends. I welcome you to this webinar. This is a wonderful webinar, and my topic is evaluation of breathlessness in GI and liver diseases. My name is Abhinav Sharma. I work in Jaipur. So whenever we are faced with a patient with breathlessness, we have to pick features which might be pointers towards cirrhosis, like history of alcohol, stigmata of chronic liver disease, low platelet, low albumin, high INR. And then we can confirm cirrhosis by ultrasound abdomen, where we find shrunken liver and collaterals. Fibroscan is there to help us. If fibroscan is more than 20 kilopascal, then it confirms cirrhosis. And if there are varices on upper GI endoscopy, then this is confirmation for presence of portal hypertension. Now, out of all these conditions which might lead to breathlessness in a patient with cirrhosis CLD, I would focus on hepatic hydrothorax, hepatopulmonary syndrome, and portopulmonary hypertension. Hepatic hydrothorax is pleural effusion more than 500 ml in a patient with cirrhosis without any underlying pulmonary or cardiac disease, and this may occur simultaneously with ascites or even without ascites. The characteristic of fluid is transudative, low protein, and we calculate SPAG, which is serum to pleural albumin gradient. It should be more than 1.1, similar to SAG we calculate in a patient with ascites. Now, if we get high neutrophil count with positive culture. If neutrophil more than 215 culture is positive, then it is spontaneous bacterial empyema, a serious condition. If culture is negative, then neutrophil cutoff is more than 500. The caveat is absence of pneumonia. It should be suspected when patient present with fever, thoracic pain, encephalopathy, or unexplained worsening in renal function in patient with hepatic hydrothorax. Now, hepatopulmonary syndrome is a triad of portal hypertension, increased alveolar arterial oxygen gradient, and intrapulmonary vascular dilatation, as seen on CT scan in this slide. Now, prevalence is varying up to 30% case. The CLD patient might have a hepatopulmonary syndrome. They present with dyspnea, platelopnea, and orthodeoxia, wherein saturation gets drop on standing and patient gets breathless. Diagnostic criteria: presence of portal hypertension. This may be with or without liver disease, arterial hypoxemia, and alveolar arterial oxygen gradient more than 15. And we have to demonstrate pulmonary vascular dilatation either with contrast echo or technician scan. This is the battery of tests. I would highlight two tests here. Yeah. So So this is technetium scan, technetium level micro aggregated albumin is injected. If we see more than 7% tracer uptake in the brain, this confirms shunting and diagnostic of hepatopulmonary syndrome. To make agitated saline, we take 9 ml normal saline and 1 ml air. We mix them up very well. We inject the contrast intravenously. First, it appears on right side of heart, and if any bubble contrast appears on left side, then this is diagnostic of hepatopulmonary syndrome. This is diagnostic of shunting, which happens in hepatopulmonary syndrome. Coming to portopulmonary hypertension, pathology is similar to primary pulmonary hypertension. This is microvascular disease. Microvasculature of lung gets constricted. Up to 10% cases might be having this condition, more common in female as opposed to pulmonary syndrome, and more so in passage of autoimmune hepatitis. The pathophysiology is hyperdynamic circulation, which puts shear stress on pulmonary vascular epithelium, which leads to modeling of pulmonary vasculature. When to suspect: dyspnea, split second heart sound, and loud P2, and any feature of right-sided heart failure. On 2D echo, we have increased right-sided systolic pressure and bulging of septum into the left ventricular cavity. But the gold standard test is right heart catheterization and direct measurement of pressures. So diagnostic criteria, again, presence of portal hypertension and presence of pulmonary hypertension, as denoted by mean pulmonary artery pressure higher than 25 millimeter mercury, along with increased pulmonary vascular resistance more than 250 dynes. We have to exclude high pulmonary wedge pressure. It should be less than 15. So this is the protocol. If we suspect, first test to do is echocardiography. If on echocardiography, right ventricular systolic pressure is more than 50, then we have to look at pressures. If mean pulmonary artery pressure is more than 25 with increased pulmonary vascular resistance more than 240, then this is portopulmonary hypertension. If right-sided pressure is less than 50, then contrast enhanced echocardiography. If bubbles are there on left side of heart, then it proves hepatopulmonary syndrome coupled with pulmonary alveolar arterial oxygen gradient more than 50. In both of these cases, pulmonary artery wedge pressure should be less than 15. Now, severity has also been categorized in hepatopulmonary syndrome according to PaO2, and in portopulmonary hypertension as according to mean pulmonary artery pressure. The severe the disease is less are the chances of success of liver transplantation, and severe portopulmonary hypertension, liver transplant is contraindicated. Coming to second topic, how GERD affects lung. This is bidirectional process, and both affect each other. What is GERD? The classical definition is reflux of gastric content to the esophagus, which results in symptoms and complications. Now, Leon has basically changed this definition to actionable GERD, means as opposed to previous definition, this definition requires objective proof of GERD either on endoscopy or on reflux pH monitoring. Now, what is conclusive evidence of GERD? It is LABCD esophagitis, Barrett's or peptic stricture, or is total acid exposure time more than 6% on 24-hour ambulatory pH metry. This is the pathophysiology, how reflux affects lungs and how reflux affect GERD. Now, conditions which are affected by aspiration can be directly causal, as we see aspiration pneumonia in ICUs, or there are conditions where GERD can be indirect aggravating factor like COPD, chronic cough, asthma, ILD, and idiopathic pulmonary fibrosis. Now we have been provided by Almighty all the defenses to which prevent against aspiration. These defenses include LES, crura, esophageal motility, upper esophageal sphincter, glottic reflexes, and lung reflexes. This is the total list of all these defense mechanisms: upper esophageal sphincter, motility, esophagogastric junction, gastric emptying, and clearance reflexes. Now, this is the table that in these 5 conditions, chronic cough, asthma, IPF, cystic fibrosis, COPD, what is the data, how these reflexes get affected. And if we see then in COPD and IPF, upper esophageal basal pressure is low. In all these 5 conditions, esophageal motility and LES pressures are low. In IPF, cystic fibrosis, COPD, gastric emptying is delayed, and in chronic cough and asthma, esophago-bronchial neural pathways are sensitized. So, but the important to note here is in most of the condition, ND is written, which is no data available. So we need to explore more and we need to generate more data. How to confirm or refute this diagnosis? There are a battery of tests. This is the long list of tests. These are the pros and cons of these tests. If we look at indirect indicator like neurological disorders, head and neck disorder, esophageal disorder, they just tell us which patients are at higher risk of aspiration, but don't provide confirmatory evidence. For confirmatory evidence of reflux, we need upper GI endoscopy and pH metry as outlined by Lyon consensus. Endoscopy also rules out the structural region. When doing pH metry, if we do only acid pH metry, then we might miss out on alkaline reflux. So pH metry should be combined with impedance to find out weakly acidic reflux or alkaline reflux. Manometry is also sometimes required to look at esophageal motility disorders like achalasia or peristalsis. This is a very good test, modified barium swallow, wherein we give 40% barium to the patient and we do videography. Here we can document reflux directly and particularly useful in neck or neurological disorders. The other direct indicator tests on bronchoalveolar lavage like pepsin, bile, and lipid-laden macrophages. Out of these 2, pepsin and bile are specific, but they lack validation in clinical scenario. The problem with pepsin is that pepsin A is not that widely available, which is very specific and it's only secreted by stomach. Pepsin C is widely available and it is done, but pepsin C is also secreted by pneumocyte, so it can give false positive results. Now, lipid-laden macrophages, they are easy to look at because only microscopy is required, but they can be also found in healthy control subjects. So these 3 tests are not foolproof. They are not devoid of fallacies. Lung biopsy is most definitive test. Whenever biopsy is required, we should also look at features of aspiration in the biopsy specimen. Scintigraphy, it is helpful in reflux, particularly during sleep. It is well established and validated method. This is how it is done. Patient is given water with the technetium phytate. Scintigraphy is done. And if we see any tracer uptake in lungs, that is a proof of aspiration. This scintigraphy has high specificity, but since sensitivity is quite low and availability is not that widespread, its usefulness in clinical scenario is limited. pH-metry and impedance. This is important. Here we put a catheter in the esophagus and do 24 hours recording. We can find out acid reflux and non-acid reflux. Do's and don'ts are there, which should we keep in mind. 6 to 8 hour fasting is required. Long monitoring should be done at least 16 to 24 hours. Nowadays, 96 hours pH-metry Bravo capsule is also available. Don'ts are this should not be done in structural dysplastic motility motility disorder, because catheter placement is not that reliable. Bed rest and dietary restriction we should not advise to the patient. Patient should be up and around as physiological as possible, so that we may look at pH tracing in his day-to-day scenario. Now, initial 30 minutes is excluded from the analysis because that can be fallacious. We need to stop antacid, prokinetic, and PPIs 1, 3, and 7 days before the starting this testing. Now, we can also detect weakly acidic reflux 4 to 7 pH and alkaline reflux more than 7 if patient is on PPI or if he has undergone some kind of surgery. Now, the pH probe has 6. pH impedance probe has 6 impedance rings and 1 sensor for pH. So total 7 sensors are there. This is the principle of impedance. Whenever between these two rings, anything which passes, which reduces the resistance to flow of electricity, impedance drops. So liquid bolus basically has low resistance to passage of current, so the impedance drops whenever liquid bolus passes. So you can see here liquid bolus is passing from left to right side. When it passes through between these two rings, then impedance drops, since liquid has low resistance, low conductivity for high conductivity for liquid passage of current, and low resistance. If we see impedance dropping from starting from above to below, then this is a liquid bolus which is traversing down the esophagus from mouth to G junction. If the impedance drops first in lower port and then gradually in upper port also show decrease in impedance, then this is a classical liquid reflux. Now, if impedance drops in lower ports only and upper ports are not showing drop in impedance, then this is distal reflux. If pH also simultaneously drops below 4 along with the reflux as denoted by impedance, then this is acid reflux. If simultaneously with dropping impedance, pH doesn't drop, then this is weakly acidic reflux. And if impedance decreases and is increases rather than decreasing, then this is basically belching or air reflux, because air has low conductivity of electricity and impedance increases. Now, these are the parameters to calculate impact of GERD on chronic cough or asthma. We have to do 24-hour synchronized impedance, pH, and acoustic monitoring. We calculate symptom index, symptom sensitivity index, and symptom association. Based on these calculations, the cutoffs have been given, and we can decide whether symptoms are associated with GR or not. This is the algorithm which we follow if a patient is referred to us with reflux symptom, if classical and dyspnea. If typical reflux symptoms are there, no further evaluation is required, only twice a day PPI. If typical GRD symptoms are not there, then evaluation by pulmonary or ENT guys. If they want, then we do endoscopy and pH monitoring, and then accordingly we modify the treatment. Thank you.
Thank you, Abhinav sir, for such an exhaustive coverage of the topic. And it has been so mind-filled that now we are having so many questions coming up in our chat box. And so, sir, now is everybody ready to go into a small question answer kind of learning style. Okay, so now
Yeah.
I think I'll start off with him.
Yes.
Yeah, it's okay. So him, now your topic was basically about a very common symptom called GERD. So what I would like to ask you is, how will you like to maybe give a few short points? Because for the whoever attendees who are not able to attend the meeting from the beginning, I just want that no one should miss what was covered in our presentation. So if him could just give a basic outline as to when you see a patient, how do you come to the conclusion, or what are the risk factors that you look at to decide that the patient is having GRD, and how do you go about the diagnosis and management from our pulmonologist point?
Thank you so much for the question, sir. I think it is very well depicted in both the talks, but let me brief, as you say. So the risk factor, let me start. GERD by definition is the regurgitation of the GI contents into the esophagus. So the risk factors are our lifestyle also: chronic tobacco chewing, smoking, alcohol consumption, pregnancy, postprandial fullness, and pathologically it is related to some connective tissue disorder also, like in systemic sclerosis we see patient. It is also seen in when we prescribe a lot of anticholinergic drugs, nitrates, and the pathophysiology behind the crux is there is an impairment of the lower esophageal sphincter or a relaxation of the lower esophageal sphincter, which allows the contents to move upward. So anything that harms that pathway will allow you to regurgitate all the stomach content from upper esophageal, then the figure I showed and Abhinav sir also showed from pharynx, and then it goes to lung and aspiration occurs. For the diagnosis, for the symptoms, they mostly come with the chest pain, dry cough, extraesophageal symptom I'm talking about, dry cough, chest pain, cough reflux, and sometimes the classic symptoms are heartburn. They will also come dysphagia, odinophagia. So these are the pointers in which I will suspect that there is GERD. The diagnosis part, I and Abhinav sir already told. The radiography helps. Barium swallow helps for echolalia cardia or anything abnormality in esophagus. But the esophagogastroduodenoscopy will help for the erosive esophagitis or echolalia or the Barrett's esophagus diagnosis. The gold standard 24-hour pH ambulatory monitoring, as the sir already explained in very detail, but it is not readily available. So esophagogastroduodenoscopy, radium, all the radiological workup and your clinical suspicious will in general setup will allow you to diagnose GERD. Mostly treated with the PPIs, as we all know, rabeprazole, pantoprazole. And if there is specific, then I have explained that if there is specific H. pylori, then the treatment guides according to the etiology also. And if it is resistant to the medical therapy, then the surgical part, listen, fundoplication can also be explored. But that is the last sort of the choice. And if there is hiatus hernia, we should do for the repair. Thank
you. That was a very good answer. But I would just like to ask you additionally, when you have sort of, obviously you have shown the gastro, maybe they've done the endoscopy or they've then taken the sampling, you have the H. pylori report, you have given a course of medication for 14 days. After that, at what frequency do you feel that a patient comes back with a repeat H. pylori after the first treatment is over?
So I think there's a problem because H. pylori is my domain. So we are living in a hyper-endemic zone for H. pylori. India population prevalence for H. pylori is quite high. As far as in one study, if they look at breath test of children more than 15 years, and more than 85% of them had evidence of H. pylori. So yes, reinfections are very common, number one. Number two, we have to be very sure that we are just giving 14 days therapy doesn't mean that we have eradicated H. pylori. Because in India, antibiotic protocol, nobody's followed. Even for viral infections, antibiotics are being misused, I would say not used. And that leads to resistance. So there was this multi-center study involving 8 sites in India, including HGPGI, PGI, Chandigarh, AIIMS, Hyderabad, and 2-3 more centers. And it was found that the most commonly used drug metronidazole, which we give in diarrhea. So up to 50% of H. pylori was resistant to metronidazole. And likewise, other drugs also, it was, but amoxicillin resistance was very common. Only drug which was not that resistant was clarithromycin. So we have to choose our anti-H. pylori therapy very wisely, looking at resistance pattern in India, number one. Number two, we have to complete the course of H. pylori treatment. And number three, we have to document eradication by stool antigen test so that we can be sure that we have eradicated H. pylori. Because just giving the regime doesn't mean that we have eradicated it. Infection resistance rates are very common, and reinfections are also very common.
Thank you, sir, for the thing. So now, sir, I'll move to Tridib, sir.
Yeah.
Sir, can I ask you, like, for example, now we'll just go into another symptom that is from the gastro system. For example, simple vomiting. Many a times patient comes to us, so they're vomiting at home. The relative brings the patient with at that point with a breathing difficulty. Or usually even in children, when babies, we see that during feeding, the mother will complain that the patient is coughing up or choking up the milk. So in those, in our normal category, okay, let's consider, we know the general causes of vomiting. But in these two maybe extreme categories of geriatric population and in a younger children, babies kind of population, if, let us say, a child comes brought to one of the consultants who are attending this seminar, and they are saying the patient is repeatedly having a coughing up of milk during this thing. So how will you advise them to address that situation?
Yeah, thank you for your question. Now, this is, before I answer the question, the basic thing here is the two things I want to stress, which is it's a practical thing. One is that when the development occurs, when we are around about the fourth week, there is the growth from the from the foregut and the respiratory diverticulum, which forms the trachea is formed. So it is forming together, and there is generally a septum which comes in, and that septum separates it. So any defect right there in the development will cause a problem. That's one. And even in a normal person, even assuming it's going, remember the oropharynx is something which is common between the lung and the GI tract. So that is where, this is why these two are so closely linked. So this is the basic thing which I would like to first stress on. Now, when we are talking about the development difficulties of this, when this kind of septum is not formed, then you can form a fistula. So typically in these children, they can have a congenital tracheoesophageal fistula, and because of which congenital fistula, which comes with this vomiting which occurs especially after milk. Similarly, in the development of, in the further growth, there could be an esophageal diverticulitis, again, which will cause the reflux, and that will again sort of go into the lung and cause cough. Similarly, as Dr. Him mentioned about achylisacardia, where the lower sphincter it is got total, there is the lower end of the esophagus is not really over, it's completely clogged there, or a pyloric stenosis. So these are the type of things which can occur during development, which can cause persistent vomiting immediately, sometimes immediately after food, which can, because of your esophageal causes, or when there's achylisa, it happens a little later. So these are things which can happen generally in the children. In an elderly, in addition to this, there is the constant, maybe there are a lot of use of drugs. They are on a lot of antibiotics, steroids, anti-inflammatory drugs, because of which there are chances of developing peptic ulcer, gastric ulcer, which can cause vomiting. Any other cause of vomiting which can happen in elderly is vascular causes. So mesenteric artery ischemia or aortic aneurysms. These are things sometimes which can cause vomiting, and that vomiting is causing aspiration with pneumonia, and patient is presenting with a respiratory symptom, but the cause of the vomiting is something else. Similarly, there could be intestinal obstruction, which volvulus or intestinal obstruction, or a neoplasm, or pancreatitis, which we will be talking about later on, which can also present with acute vomiting. And sometimes some of this, there could be trauma, which can cause esophageal rupture. And in that case, in addition to vomiting, there is very severe mediastinitis, pneumomediastinum, and which can be a problem. Another cause of vomiting in children, in young children as well as adults, is chronic sinusitis. And this typically, which happens, is that early morning they get up with chronic nasal discharge followed by vomiting. So always think of that as the cause of vomiting. And the lung itself, so post-tussive causes, so a big pneumonia or a pneumothorax may cause such a lot of cough that it may, the epiglottic reflex will be disturbed and you may get vomiting, which will further aggravate the basic lung condition. So this is in a nutshell, which specifically the developmental defects between children and in elderly, in addition to the regular things, these ischemic causes or these valvular causes. I forgot, there's sometimes an inferior wall infarct can also present with, because of stimulation of lower brain tap. Of course, it's not a very common cause of vomiting and, an aspiration pneumonia, but it should keep in that, it is one of the causes. So I think this is in a nutshell with these two extreme ends, which I would like to. Thank you.
Thank you, sir. Sir, now I think I'll ask Sir Vishnu Sharma, sir. Vishnu, sir.
Yeah.
Sir, you being a doyen in pulmonary medicine, sir, you would have been telling countless patients and families over the years from after you left Kerala after your MBBS time. Sir, you must be telling them that tobacco is a dangerous item for our respiratory system. So, sir, I would just like to ask you in two angles. One, if the tobacco is tobacco chewing, does that tobacco chewing affect the respiratory tract? And secondly, does smoking tobacco affect the gastric tract? So how would you like to just explain to us what your experience is over these many years?
Yeah. Any form of tobacco is associated with increased risk of cancer, whether it is smoking or chewing. Lungs are not an exception. Even chewing can also cause increased risk of malignancy in the lungs as well. But compared to smoking, the chances are less. Chewing tobacco, yes, definitely it causes a lot of problems. But the problem is more with the upper GI. The chewing tobacco causes is the main cause for oral cancer. The cancer, especially in the North India, it is very common. So tobacco chewing is very common. Compared to Kerala, it is much less in Kerala, tobacco chewing. And then coming to the risk of upper GI problems with smoking, there's an increased risk of GI malignancies, both the esophageal and stomach cancers, as well as the large intestine colon cancers with smoking. And inflammatory bowel disease, when it comes to ulcerative colitis, that is the only disease probably which has got a beneficial effect with smoking. Whereas Crohn's disease, the counterpart, again the risk of Crohn's disease increases with smoking. And smokers are more prone to develop liver cancer as well, chronic hepatitis, and gastroesophageal reflux disease, and peptic ulcers. This is a well-known fact. I think I answered your query.
Sir, thank you so much, sir, for your elaborate explanation. Sir, now I think I will ask our guest speaker, Dr. Abhinav Sharma. Just now, he has given us an extensive talk, very detailed about the entire gastric topic as much as he could cover in this short time. But I would like to ask him specifically, Abhinav, sir.
Yeah.
So I would ask you, like in general, how would you, for example, now you know that we being pulmonologists, we are not too experienced or keen much into the liver and the abdominal process of diseases, though we are involved at certain points of time when both the systems meet. But the problem coming over here is, would you just give us because as we have a large audience, and as Krishna sir has just updated, we have more than 1,269 logins from all over India attending this talk. And sir, I would like to ask you, how would you guide pulmonologists on the simple points as maybe CLD, POPH, hepatopulmonary syndrome, hepatic hydrothorax? Which of these, let us say the patient is coming to us for a respiratory symptom, but which of these points, if we identify, we are supposed to escalate it immediately to a gastroenterologist so that the patient does not lose the option of treatment early in their disease process?
So I would cover them one by one. So hepatic hydrothorax is basically condition in portal hypertension where fluid accumulates in the chest. So whenever fluid accumulates in the chest, the first the tendency is to put in a tube to drain it through the tube, and which is a big mistake in case of hepatic hydrothorax, because in hepatic hydrothorax, if we put in a tube, this will continue to drain and it will be difficult to remove the tube. So it becomes a continuous process. It becomes a burden. That's a mistake. So rather, we should manage these patients with, like we manage ascites in CLD. We should restrict salt. We should restrict fluid. Salt restriction should be to the tune of 2 grams per day. That is 88 milliequivalent in a day, because that is the renal excreting capacity in a CLD patient. If we go beyond that, then the patient is going to retain sodium, and sodium will in turn retain water, and water will further worsen the hepatic hydrothorax. So diuretics, salt restriction, and sometimes fluid restriction, that is the way to manage hepatic hydrothorax. Do not put in a tube. But with a caveat that if a patient with hepatohydrothorax comes to you with fever, chest pain, and any kind of worsening, then put in a needle just to aspirate to rule out spontaneous bacterial empyema, because missing this condition will be catastrophic and patient may worsen and die. So if we diagnose as spontaneous bacterial empyema, the antibiotics should be administered very rapidly. So the take-home point in hepatic hydrothorax is do not put in a tube, manage conservatively. Secondly, any patient with CLD, if he has dyspnea, we have ruled out hepatic hydrothorax, then next comes hepatopulmonary syndrome and portopulmonary hypertension. Why should not we miss them? Because missing them will be we might put them off the liver transplantation list, and these are the candidates for liver transplantation, since the definitive treatment for this condition is liver transplantation. So early identification, early suspicion, and early treatment is mandatory, though it has not been shown that early treatment will modify their course, but at least we would be wiser and we would be able to prognosticate the patient. And since liver transplantation is the big task, patient has to arrange for donor, for finances. So diagnosing these patients early will give them a chance to prepare for all those future things. Secondly, when managing this patient, you should not only look at the lung, you should also look at the liver condition also, whether this patient is child A, whether he is child B, or he is advanced cirrhosis. So we should look at his liver function overall. We should look at his overall condition like performance status and sarcopenia, his nutritional status, so that we can assess patient in toto, not the lung per se. I hope I'm clear. Yeah.
So would you consider that ultrasound abdomen should be maybe a basic investigation that a pulmonologist also does to be able to assess?
There are the two situations. One, established cirrhosis patient comes to you with these complications. So we know that this is patient with cirrhosis. Only thing we need to reassess them is for new development. And what is new development in a cirrhotic patient which make them worse, which leads to worsening, is development of hepatocellular carcinoma, which might require a repeat ultrasound or maybe contrast enhanced triple phase CT scan. So yes, ultrasound has a role. And another scenario is we don't know the patient has cirrhosis. He was just seeing one physician to other for his breathlessness, and we don't know whether he has underlying cirrhosis or portal hypertension. And then he is being referred to a pulmonologist for evaluation. And we should keep in mind that this patient might be having underlying cirrhosis. The pointers also we mentioned, we saw in the first slide. If the patient has a significant history of alcohol, if he has high risk behavior, which might put him to hepatitis B or C risk, or if he has frank stigmata of chronic liver disease like jaundice, clubbing, though it can be there in pulmonary disease also, but anasarca, spider nevi, palmar erythema, caput medusae around umbilicus, presence of ascites. These are strong clinical pointers towards liver disease. If any of these pointers are there, and even if they are not there, if you're suspecting liver disease, then simple ultrasound abdomen should be done. And if we find a nodular liver, dilated portal vein, splenomegaly, presence of collaterals, then these are short signals that this patient might be underlying chronic liver disease. And if we suspect that, if we further want to confirm that, then one more non-invasive test is nowadays available, that is called FibroScan. FibroScan is nothing but it measures elasticity and stiffness of the liver tissue. As fibrosis increases, liver gets stiff and FibroScan values or gets altered. So if FibroScan value is more than 12 kilopascal, then this patient is probably having significant fibrosis. That in our term, we call it F4 fibrosis. And if FibroScan value is more than 20, then this person is having frank cirrhosis. So that is the way that is how we evaluate these patients when it comes to you. So at your hand, you have clinical things, you have ultrasound, and maybe your hospital has FibroScan if you suspect cirrhosis.
So thank you for explaining this so much for us to understand. And sir, I'll be coming back to you with more gastro questions. So now I'll ask Dr. Him.
Yes.
Now you know that all of us, we know that we have multiple routes of drug administration. For us, the priority is the nebulization IV routes. But 90% to 99, 100% of our patient load also have orals to consume. And all of these patients are on usually prolonged oral treatment, and everything goes through the gastric tract. So have you ever felt that when you started your respiratory medicines, patient developed gastric symptoms due to that, or patient was maybe on, or maybe some change happened in their existing drug regimen, some drug interaction happened? Did you have any issues like that with any patients concerning the gastric tract and our medications?
Yes. So this is quite common scenario when the patient is on chronic respiratory drugs, be it any group. So let me first start with giving example of theophylline. So basically, although our GINA and Gold has a big no to oral theophylline, but to primary care center, and secondary, more of the secondary care center also, a lot of physicians and GPs prescribe the theophylline. Although we all know it should not be used, but what it causes is PD3 and 4 inhibitors. So it relaxes the smooth muscle. It causes chronotropic effect. It increases the heart rate. And the topic we are concerning, GERD, it gradually develops to that phase. So chronic theophylline use will have the nausea, vomiting, will have the heart rate increase, and you're still prescribing the deriphylline. Now you're prescribing more with ivabradine and all the antiarrhythmic and PPI, but you are not finding the cause that the culprit is the deriphylline, which has been used from years and years. So the toxicity level or the trough level should be measured, like it is 5 to 15 microgram trough level should be there. But the problem is whenever the theophylline is prescribed from whichever the center must not have that trough level facility available also. So this is two-way sword to the patient. So one is theophylline, which is not to be prescribed but over-prescribed in our Indian scenario. Second, steroids, oral steroids, which is, I'm sure, in our daily practice, everyone has to prescribe for exacerbation or for ABPA or for chronic sarcoid or autoimmune disorder or vasculitis. So when we prescribe chronic steroid for 6 months, 3 months, year, we all know it's going to cause some of the gastric effects. So the PPI combination works there. We all prescribe the PPIs along with it. Basically, steroid causes impaired wound healing, inhibit the angiogenesis, And a lot of patient, I don't know whether you have, all of you must have experienced, a lot of my patient come with the hemorrhoids. That doctor, I have started bleeding for rectal. It was there 5 years before, but now you give me these drugs and now I'm having this. So this is one very common scenario. There is anemia also is there. You will not able to find. There is, the HB will fall. You just see report WBC is increasing. You see platelet is falling or rising. But if you carefully monitor the chronic steroid patient, the HB is slowly going down. Then you have suspicious of gastric ulcer or a peptic ulcer there. So this is second common scenario where our respiratory drugs are the culprit for the GI symptoms. And thirdly, antibiotics. So antibiotics, I think we all know. If I go in every detail, then it will be long time. But we should have a suspicious that antibiotic of chronic use will have double-edged sword. It improves also and it deteriorates also. So we have to judicially prescribe the antibiotics and judicially prescribe the PPIs also. There are a lot of side effects of PPIs giving irrationally and without evidence of symptom of GERD or gastric or peptic ulcer. So this is also a common practice at PHC center and the secondary care center. And you don't know what side effect you are giving to the patient. And the patient also doesn't know, because after 2 years, whatever osteoporosis or any side effect of long-term PPI use will not be measured. So I think these are the common scenarios which are very prevalent but not documented as it is prevalent.
Would you mind if I just add one point to your list?
Yes.
Nasal sprays. That is
Correct.
also a very important category, because many times I've seen that when you add acylastine and fluticasone combination, the patient always comes back with an additional throat irritation or a nasal drip.
Invariable.
Fluticasone is much lesser in that thing. But what I would like to maybe give as a knowledge is that when you advise them to take the nasal spray,
Yes.
what they do usually is 99% of the time, if you don't check the technique, they're just pushing it and inhaling it in. So that action should be stopped. When you take the spray, they're supposed to hold the nose, put the spray, close the nose. So when you close the nose and you hold it, the medication only in this area. It should not have the sinus or into the gastric tract. That much it resolves this complaint, and you don't have to give an additional PPI just to control the GRD due to the nasal spray. So that
has been observed, already highlighted by Chatterji, sir, the chronic sinusitis component also, which chronic cough, which lead to the nausea, vomiting, that has already been discussed also. And the spray technique, it should not be on the septum, should be on the sideways. So there will not be a long-term side effects.
But we should not inhale it inside. Should not be
correct.
That is the most important.
Correct.
Thank you, Dr. Hen. So now I'll move to the Tridib Chatterji, sir. Sir. Tridib, sir?
Yeah, I can hear you. Go ahead.
Sir, I want to go into a bit more of a broader kind of topic. Let us say now, as you being a very senior, experienced pulmonologist, you'll be getting lots of kinds of breathing difficulty patients and patients in hypoxia. But where have you found in your particular experience that a patient is maybe not having much of a history of breathing difficulty prior, but now the patient comes to you with maybe a new type of breathing difficulty, and which is somehow you feel that it is connected to the liver or connected to the gastro. So that kind of a situation, and maybe a liver cirrhosis patient, how will you approach that route of thinking?
Okay, nice question. So basically, the liver is also very. Actually, two of them we have already discussed, but we have to go through that. One, as Dr. Abhinav and we have already talked about, is the hepatorenal. So where it's any kind of cirrhosis or any end-stage liver, sometimes in acute liver, but generally it is in the very chronic liver disease. There are this is hepatorenal, because what happens is that there is a increased pulmonary the vasculature gets dilated. So because the pulmonary vasculature gets dilated, the blood supply moves so fast, there is not enough time for oxygenation to happen. The tracking time, movement time is so fast that you do not get time for So patient generally present with hypoxia. And a very typical feature which is seen is what is called as platypnea or orthodoxy. That is, the patient generally start getting more breathless when they sit up rather than sitting down. And So much so that there could be a drop in oxygen by more than 5 to 10%, which is called as orthodoxia. So in a cirrhotic patient with ascites or some, as Dr. Vishnu said, mentioned, who was clear evidence of portal hypertension, if you have this, then you must think of hepatorenal syndrome. And of course, he has mentioned in detail technician scan and the bubble scan, which I don't want to repeat, but that is one. The second is again in the cirrhosis, or rather in any end-stage disease, liver disease, is the portopulmonary hypertension, where you have got evidence of pulmonary hypertension, group 1, where it is not explained by congenital or HIV or any vascular disease, and patient also have evidence of portal hypertension, and you do a right heart cath, or you do first, you do your echo, and you prove that you have pulmonary hypertension. If you can do a right heart cath, that is very great, and you show a normal pulmonary vascular resistance which is more than 200 or 3 or what. Sometimes nowadays we are using Wood units, so more than 3 Wood units is there. So these two together, but here the technique is that it is vasoconstriction. It's not the unlike that, and this is the 2 patients which you have to then evaluate for liver transplant, because otherwise there is no treatment. But in addition to this, there are another 2 things which I found out when I was looking at this. One is the ischemic liver or hepatic hypoxia. So patients, elderly patients especially, who present with acute cardiac cardiomyopathy with severely decreased cardiac output or circulatory collapse, can present with what is called as hypoxia, because a massive increase in the liver enzymes to more than 20% because of severe congestion of the liver. So the SGOT-PT will tend to go more than 20 times the normal. Of course, these have to be differentiated from viral hepatitis and other pancreatitis, but patient is presenting with a cardiac, in a cardiomyopathy, with a cardiac shock. You many times you will find that their hypoxia and the SGOT-PT are in thousands, 2,000, 3,000, and they rapidly come down once you treat that. So this is called as ischemic liver or hypoxic liver injury. So that also is something which is, it's not a primary liver defect. It's not that the patient has got a primary cirrhosis or something, which the other 2 where there is an end stage. Here the liver is normal, but the liver is under hypoxia because of the poor circulation and congestion. That's one condition. And another thing which I found, and nowadays many times you do sonography and they report it as fatty liver, grade 1, grade 2, all kinds of grades. So that is the non-alcoholic fatty liver, that NAFLD. So there is the chance of this progression to NASH or cirrhosis. Here, hypoxia, which can occur because of a respiratory cause, is primarily obstructive sleep apnea. As you know, most of these fatty liver generally happen more common in little obese patients. And in these obese patients, 25-30% of them have got sleep apnea. So in these patients who have got sleep apnea, this NASH progresses NFLD more rapidly progresses to NASH, and you can go into cirrhosis without being an alcoholic. So here the respiratory cause of sleep apnea is aggravating a liver fatty infiltration, and because of obesity, diabetes, and these our lifestyle changing, these things are becoming more. And in these trials have shown that when these people are put on BiPAP and CPAP patient, the progression of the liver disease also decreases. So this is another important data which I found out when I was preparing for this lecture. So this is regarding hypoxia with liver. I thought more of these 4 or 5 causes.
Thank you, sir. Thank you for your detailed reply. Sir, now I'll ask Vishnu Sharma, sir. Vishnu Sharma, sir, tuberculosis, as you know, is our bread and butter. And from the Vishnu, sir?
Yeah, I'm here.
Sir, the thing is that now from the moment we start learning about tuberculosis drugs, the one thing drilled into our head by our faculty is that it should always be had empty stomach in the morning, because any sort of dilution with food or anything else at the same time of TB drug consumption will reduce the bioavailability and the absorption from the tract, and the blood levels will not reach the optimum levels which we need for TB suppression. But sir, as you know, all of our patients, nobody can tolerate the ATT in the morning in an empty stomach, at least initially. And it causes so much, sometimes irritation to the patient, that sometimes even patients become non-compliant to the TB regimen, which we so strictly wanted to be compliant with. So, sir, with your experience in handling all sorts of TB patients, sir, how do you guide our audience as to one thing is how to place PPI in their ATT regimen for optimal usage, such that it does not affect the TB drug absorption? And sir, another thing is there any other, for example, during the ATT course, many times we find LFT variations coming up. And so I know it's a very, very deep topic. It is not possible to go into that in this small question answer session. So, but just as an outline, how should somebody approach an LFT if there is a derangement happening on ATT? So these two topics, sir, for you on TB tuberculosis.
Yeah. As far as possible, antitubercular drugs should be taken as a single daily morning dose. But then there are few patients who may not tolerate it, and most often it is the pyrazinamide that causes gastritis rather than the rifampicin. So at least those patients who are not tolerating, at least give INH rifampicin on empty stomach, and then half an hour after that a breakfast, and then. But only problem is with the NTP, we don't have the option of giving these drugs separately. But then, a good counseling before we start ATT, because most of the patients initially, as you said, 5-10 days, they get used to the drugs. So tell the patient, counsel the patient that there is going to be some kind of, upper GI symptoms initially, but it will settle with time. You will get used to with the medication. That is very important. And what I do usually is initial 5 to 10 days, give them a PPI. There is no harm. Give the PPI initially, and then after 15 to 20 minutes, ask them to take the antitubercular drugs. They tolerate. But then most important point to remember is do not give any antacids, because antacids will definitely hamper the absorption of antitubercular drugs. PPI, yes, we are justified. Secondly, if any patient has got any upper GI symptoms, especially in the form of intolerance, LFT should be repeated, because liver function abnormalities are the most common and the serious adverse reactions, which usually occur within the first 2 months. So any patient who has got a new onset of upper GI symptoms with antitubercular drugs, a baseline LFT always should be done before starting ATT, and a follow-up LFT should be done in those patients, especially look at the enzymes, because the liver enzyme elevation is the first thing to occur with antitubercular drug induced hepatitis, in which case we need to modify. And drug induced hepatitis usually it doesn't occur late. So within the initial 2 months, if the LFT is normal, I feel that there is no reason to repeat the liver function abnormality if there is no pre-existing liver disease.
Sir, so when you're giving the initial PPI with the ATT in the beginning, at that time, sir, you give a short course. And later, at what point do you decide if you want to evaluate for H. pylori also in the same patient? Because then again, we have to add more antibiotics to control the situation. And those are drugs which may overlap with ATT, and everything together patient may not tolerate. So, sir, how would you just guide us to go into gastric ulcer, that kind of assessment in a TB patient?
Same with the persistent upper GI symptoms, where the patient is not tolerating, has got continued symptoms despite PPIs, and the LFT is normal. Then you may need to evaluate further. Otherwise, not.
Thank you so much, sir. Sir, sir, I'll ask Dr. Abhinav Sharma, sir, our guest for today.
Yeah.
Sir, we have just for your experience that if patients who are already being seen by a pulmonologist, or maybe on other medications of a pulmonologist, and how far do you find that maybe a particular disease called gastroparesis, how much do you feel that worsens the outcome of the pulmonology treatment itself, or brings non-compliance over there? And or is there an easy way for us to deal with that matter? And how do we detect?
So basically, gastroparesis, especially milder variety, that is underdiagnosed and underreported, since India is now considered diabetes capital of the world, and we know that long-standing diabetes tends to end up into diabetic autonomic neuropathy, and that is that is the reason for diabetic gastroparesis. So the clinical pointers, I would say, by the history, if we want to know that whether a patient is having might be having diabetic gastroparesis or not, is simply postprandial distress kind of thing. Means patient gets bloated up after a meal. So that is the clinical pointer that this patient might be having deranged gastric emptying. And in early diabetic gastroparesis, typical symptoms like vomiting and weight loss, they do not happen. So early, if a patient is having long-standing diabetes and if he's having a postprandial distress kind of situation, then we might suspect that patient might be having diabetic gastroparesis. And what are the implications as far as pulmonology is concerned? Since gastroparesis per se delays gastric emptying, so it affects absorption of orally given drugs. So drugs, they remain lying up in stomach, especially if these are entry-coated preparation supposed to be released in alkaline medium, which is there in duodenum. So drug will not get released in stomach, since in stomach pH is acidic. So that hampers the absorption of drugs. Number one. Number two, the gastroparesis situation is a predisposing condition for gastroesophageal reflux. And gastroesophageal reflux, you know that it is a condition which tends to worsen all kinds of respiratory diseases, be it bronchial asthma or chronic idiopathic cough or idiopathic pulmonary fibrosis. So these are the factors where gastroparesis plays a role, and we should be watchful about this condition when dealing with our patients.
Thank you, sir. That really answers quite a few of the issues we face in our patients after starting our treatment with them. Thank you, sir. Dr. Him, I would like to come back to you.
Yes.
Yeah, Dr. Him, now I want to just give, for example, now most of our audience might get patients who are not very educated. They may be not able to exactly decipher their symptom which they are having. So, for example, many times a patient comes to the OP that they're not sure did they have a coughing of the blood, or they had a retching of the blood, or it was a combined action, or was there some particular stimulation for that to happen? They're usually very confused, or is it just oozing of blood from the mouth? So, can you just give an outline as to if the patient is maybe, like for example, patient comes with just the word that's maybe it's blood spitting from the mouth. How would you think to classify it into hematemesis versus hemoptysis? And what will be a simple, easy way to go about it?
Correct. Sir, this is again a common scenario for a pulmonologist to encounter hemoptysis versus hematemesis. So to go bedside to this topic, most of the time patient comes in OPD if it is scanty or mild hemoptysis, or in emergency if it is severe hemoptysis or massive hemoptysis or hematemesis. So most of the time when you in such condition, the patient, when they see blood, they are scary, very scary. So when you start evaluating and asking whether you have coughed out or whether you have vomited out, first you have to calm their anxiety. It's okay, I'm here. You calm down, because seeing blood for layman people is not a routine thing. So after this, you go to book side of this, that if it is from the cough, it is hemoptysis. If it is with nausea, vomiting, it is hematemesis. Then you ask what was the color and amount, both we investigate. So mostly hemoptysis is bright red and hematemesis is dark brown due to acidic pH of the stomach, may be associated with the food particles also. So you ask them whether something came out, like something food came out. Most of the time I see with the evaluation of mobile, many of my patients come with the picture. Sir, this much has came out. Sir, this was the color. This was the amount. Now you decide what to do with me. So these are the way they present to us. So now going with the history, whether it is lung symptoms or the GI symptoms, whether it was a post-tuberculosis condition, whether it was some lung issues were there in past, you evaluate for dry cough, dyspnea, or you go GI side. whether it's nausea, vomiting was there, whether he's alcoholic, whether he's chronic liver disease patient or not. You go that side also. Now going downwards, then you go to labs. You see, evaluate for both conditions for CBC first, whether HB is falling or not. You go for the coagulation study, whether PT-INR is deranged or not. You go for urea and platelets also. After this, you decide whether you want to investigate lung or you want to investigate GI. So if you want to investigate lung, go for sputum microscopy, chest X-ray, further evaluation with HRCT thorax, further evaluation with bronchoscopy. You came out this side. For GI side, I think you very well explained by Abhinav Sharma sir, USG abdomen, LFTs, upper GI scopy will help to diagnose hematemesis. And this how you sorted out both the condition, and then you treat accordingly whether it is a lung condition or whether it is a GI condition. Patient might not be knowing whether I coughed out or whether I vomited out. And one more important thing, start from examining from the oral cavity also. Sometimes just the oral ulcer or sometimes just the caries come with the scant hemoptysis and they are very furious that, oh, my blood is coming out from my mouth. So start from oral cavity and then go downwards, what all I have explained.
And usually asking the habits, if they have chewing or smoking, means usually get from that direction something. But the problem over there is usually the patient's concern about, and our concern of any litigation coming. If we don't manage the patient appropriately at that spot, gives us a stress. Anyway, thank you very much for your good explanation on that topic. And now I'll take Tridib sir. I think we'll go back to a bit more of theory and into that, sir. You had mentioned regarding the pancreas. So I would like to ask you that if we have a patient who's a gastro patient, or we are getting a consultation, many a times we are having a multidisciplinary team in the hospital, we get a consultation from the gastro doctor or the surgical team, that they're having a patient who's having maybe acute pancreatitis presentation, maybe a recurrent pancreatitis presentation, maybe a pancreatic insufficiency of some sort. So in which of those situations, and how would you consider a pulmonologist should intervene in those situations?
Yeah, that's see, the pancreatitis unfortunately is slightly becoming more common now because of, again, excessive alcohol and gallstones, which is occurring again because of hypertriglyceridemia, having food which is not very healthy. So acute, these are two most common causes of pancreatitis. So pancreatitis by itself has got its own significant mortality. But pulmonary system involvement in pancreas is a very major predictor in determining the outcome. So pulmonary infiltrates and atelectasis is seen in about almost 15 to 20%. And pulmonary effusions can go as high as 50%. So if these are, especially if there are pulmonary effusions, and they are usually left-sided, but can also be bilateral. Typically, these effusions are not very large, they're small, bloody, and the amylase levels, once you tap it, they will be very high, much more higher than the serum amylase level. If you get these along with pancreatitis, these are very poor prognostic markers. And in about 5 to 15% of the cases, they present with frank ARDS of mild to moderate, where there's a PaO2, FiO2 massive 200, 300, depends on severity. These are happening because there is a blockage of the lymphatic ducts and a direct pleuropulmonary connection between the pleura and the pancreas and into the lungs. So the lung involvement when you get a referral from a GI person, that patient is breathless with pancreatitis, and you see parenchymal shadows, and if you're able to do a scan, you see ARDS picture or effusion, you know that you can be rest assured that this patient is going to have a pretty tough time. It becomes a very severe predictor for his outcome, which for the pancreas. Now, so far as chronic pancreas, the literature is not very clear, but they have some people who have got chronic pancreatitis, they have followed up just by doing PFT, and they have found some restriction in the DLCO levels. So that means there also, over a period of time, the lung goes into some sort of restriction, maybe fibrosis, but the more acute situation is when you have the acute pancreatitis, where the lung predictor, of course, other organ involvement also is a predictor, but the pulmonary involvement of these infiltrates, atelectasis, effusion, ARDS becomes a major determining factor in the outcome of that patient. That's what I would like. That's what I can.
Thank you. So elaborate. I have nothing more to add, sir. Thank you.
Dr. Vishnu Sharma wants to add anything from his side as a gastroenterologist.
Vishnu Sharma, sir.
Anything you would like to?
Chronic pancreatitis, pleural effusion is very common.
Yeah, I said about that. Pleural effusion, they have said it is about generally left-sided, but about 20% of the time it can be bilateral.
And pleural fluid amylase will be very high.
Very high. Yes.
And by the time in the effusion occurs in a chronic pancreatitis, serum amylase will be normal.
Yes. Generally, these are very high. And this becomes a predictor. You know that you are in for a long haul.
So the outcome would be that if you have a patient who is having this kind of presentation, in the beginning itself, we should go with the bad prognosis itself.
So you have to, so Doctor, our gastroenterologist, sir, you have anything to add to this? You treat much more pancreatitis. So.
Yeah, actually, prognosis in acute setting is not that bad, because it is a part and parcel of the disease per se. But in chronic pancreatitis, sometimes effusion can be chronic because of what we call pancreatic ductal disruption syndrome. Because in chronic pancreatitis, duct is irregular, it is fibrous, it is dilated, and there might be a stone sitting at the near ampulla, which increases intraductal pressure. So if such patient develops pleural effusion, it is because of most likely pancreatic ductal disruption syndrome. And these effusions are difficult to manage because they tend to persist until you hit the cause, which is the duct. You have to drain the duct very well, and these effusions are chronic. The tract is already mature. From pancreatic ductal lesion, the leakage to pleura, the tract is mature. It is a thin tract, difficult to identify and difficult to manage. So obviously, yes, you are right that chronic pancreatitis effusion have poor prognosis and they are more troublesome kind of effusions. But in acute setting, they are part and parcel of the game.
But if there is a ARDS, then there is a bad.
Then there is a problem. If there is a ARDS,
especially if that happens early in the course of pancreatitis.
Generally, of course, by chance, it may not be only ARDS. You can get other organs, the kidney failure also along with that. It is a multi-organ thing which involves, but lung is an important part of that.
Yeah.
Predictor.
Sir, Vishnu Sharma, sir, I want to go to maybe a bit more general topic like systemic sclerosis. So we know that it is a disease which is not having a specific fixed presentation of evolution. But sir, how would you feel that what pulmonology or gastro symptoms which a patient presents with will point us towards, we should think towards systemic sclerosis?
Yes, skin changes are more important because the respiratory or the GI symptoms in systemic sclerosis are non-specific. The GI symptoms will be mainly because of dysmotility. So the patients may complain of some symptoms like heartburn, distension, and constipation, and so on, which are quite non-specific. Of course, the respiratory symptoms are those due to ILD, where the patient will present with progressive breathlessness. So any patient who has got a skin changes in addition to either a GI or respiratory symptoms needs to be evaluated for systemic sclerosis. So look at the skin, have a good general examination. That would be the same.
Thank you, sir. Sir, and sir, now we'll have Abhinav Sharma, sir. Sir, I would like to ask you that we have this investigation called bubble echo, which you have already spoken about in your topic. If you can just tell us that these kind of specific investigations, or even in a patient of maybe a recurrent pleural effusion, which is not maybe completely diagnostic, and where would you start thinking of this, guide us that we have to think into the CLD evolution, or even maybe which of these patients we should think as a high-risk case, which may require to be monitored or managed from early on by a gastro doctor for the sake of liver transplantation?
Yeah. So you are right that hepatopulmonary syndrome patients should be listed up for transplant early in the course, because without transplant, their prognosis is not going to be good and their survival is limited. So if we delay the transplant, what would happen is basically these patients get sarcopenic and they are nutritionally depleted, and transplant results are not that good. So to diagnose them early, if we get only effusion without any evidence of chronic liver disease, that we have to look at subtle changes like spiral nevus here and there on the back of the patient, or a simple palmar erythema, which is sometimes we don't look at and we miss. Pedal edema may be a pointer, subtle ascites may be a pointer. So we have to look at these pointers. Then simple ultrasound will tell us about collaterals, portal vein diameter, liver nodularity, and splenomegaly. And if doubt is there, then obviously fibroscan, a score of more than 20 and presence of varices may give us a clue to the presence of cirrhosis. And if significant alcohol history is there, or if HbSAg or HCV is positive, then again we should proactively search for liver disease in these patients. So this is how we evaluate.
That was very nice reply, sir. And sir, I'll move to Dr. Him now.
Yes.
Dr. Him, now we're actually reaching almost 9:30. So now we still have to cover a bit of few patient questions are there from the audience. So I'll just ask one of the most basic questions is that when we are, for example, now for my practice, I use etopride, levosulfide, domperidone, metoclopramide. Many of these prokinetic gastro drugs we have to end up using for our work. But so now, how will you consider the point to advise people who are listening, as do any of these gastric drugs that we use actually hamper the effect of the respiratory drugs? And if they don't, how would you like to, how to manage the prescription with good prescription writing, in how to combine this category of drugs?
Okay, sir. So I have read the chat box question. There is one question also which I will cover, that whether prokinetics are used in GERD or not. There was a question by somebody. So I'll answer that also. So we'll take one also that from there. So most of the time when we prescribe the common PPIs, it is invariably associated with one prokinetic, like omeprazole, domperidone, rabeprazole, domperidone, something. It invariably combines with the domperidone or etopride or levosulfide, invariably. Most of the time I see prescription like that. So I'll just briefly give you one of the important point is the domperidone, which is prescribed very largely and huge amount in many patients. It is D2, D3 receptor antagonist peripherally acting, but it is CYP3/4 inhibitor. So the QTC prolongation risk is very high when it is associated with amiodarone, when we give azithromycin. A lot of CAP patient or URTI patient, we use azithromycin. We use levofloxacin as secondary, a second line AKT also. So in those patients, the QTC prolongation risk are very high. And the various studies shows that the cardiac risk with using amiodarone and all, it increases with 70%, up to 70%. So while prescribing the domperidone component, you see whether you are giving azithromycin, levoflox, or the QTC prolongation drugs. You check mark that you monitor that. You monitor QTC level, corrected QTC level, if you want to be prescribing domperidone only. Other drug, etopride also. So most of the time D3D, it is also a D2 receptor antagonist, and along with it, it has acetylcholinesterase inhibitor action, ACH inhibitor also. So if you prescribe anticholinergic along with it, in our scenario, ipratropium or a glycopyrronium, so it will, though it is prescribed mostly on an inhalational form, but it can reduce its efficacy also. So that is also need to be in mind. Otherwise, the metoclopramide or levosulfide mostly not much interacted with our respiratory drugs. But of course, you can't go and give them blindly, because it has a lot of neuropsychiatric and neurological adverse effect. And I think Abhinav Sharma sir can enlighten more on that.
Yeah. So what you highlighted is very common co-prescription with the prokinetics in GERD. See, the treatment, the cause of GERD is acid into esophagus, and treatment is basically PPIs. not the prokinetic. Prokinetics are needed only for dysmotility, which is highlighted by postprandial bloating or early satiety kind of symptom, not for GERD symptom, which are heartburn, regurgitation, and atypical symptoms. Yeah.
Thank you, sir. Sir, now I'll ask you, sir, can you just also guide along with the topic that for us as a pulmonologist, now we already spoken about all your investigations. So where would you place, for us, example, upper GI endoscopy, manometry, H. pylori, IgM, IgG, ultrasound abdomen? These basic investigations, how would you advise for a pulmonologist to apply in their workup for the patient?
Yeah, so ultrasound we have already discussed. Whenever you suspect underlying liver disease, we have to basically do an ultrasound. And then coming to GERD spectrum of disorders, you ask about the upper GI endoscopy and H. pylori. So upper GI endoscopy is nowadays required if you want to label a patient as a GERD. You need a conclusive evidence, and that evidence is not a early esophagitis, not just erythema, not LAA esophagitis, but significant size erosions, which is LA Los Angeles grade B, C, and D erosions or ulcers in the lower esophagus. So upper GI endoscopy is required to prove presence of GERD. Now, if you're doing upper GI endoscopy, then test to do is take a biopsy from the antrum and do what we call rapid UDS test, which is a very good test. It is bedside test available in the endoscopy room and takes just a couple of minutes extra to do, and the results are immediately available. And it is better sensitivity and specificity, more specific than IgM and IgG, because IgM is not that sensitive and IgG denotes just past infection. Since H. pylori is a mucosal surface organism, it induces IgA response more than IgM and IgG because it is not an invasive organism. So if you are going for upper GI endoscopy, then rapid UDS test is required to prove or disprove H. pylori. And if available, hydrogen, the urea breath test for H. pylori is most sensitive test. If it is available, then that should be done for screening of H. pylori in GERD patients.
Thank you, sir. Sir, and now Vishnu Sharma, sir, I would like to ask you that we have already discussed this topic earlier. I'm just covering it one more time. Now, if you're looking for a tracheoesophageal fistula, it's a very basic complication for us to connect between the respiratory and the gastro tract. But sir, at which point would you advise us to go actively into the investigation to find out whether that this symptom is caused by a tracheoesophageal fistula or not?
Yeah, tracheoesophageal fistula, when it is congenital, it has to be diagnosed within the first 24 hours because otherwise the mortality is very high. So any newborn has got a feeding problem, consider tracheoesophageal fistula as a differential diagnosis, especially choking while feeding. That is for the pediatrics and neonates. Whereas adult tracheoesophageal fistula is always acquired. In the majority, it is either due to some procedures, trauma, or malignancy, especially esophageal malignancy, because esophagus, especially the upper part of the esophagus, is very close behind the trachea. So neglected cases of or advanced cases of esophageal carcinoma are the ones which come with the tracheoesophageal fistula. So any person who has got choking or coughing while oral intake has to be considered as a differential diagnosis for tracheoesophageal fistula. But then other GI motility problems or swallowing problems due to neurological diseases also should be taken into consideration. So a proper history, clinical examination, and examination of the oral cavity, especially if the patient has got a bulbar palsy, again, the same symptoms will be there, will help us to differentiate. So if there are no obvious neurological symptoms associated, no evidence of any bulbar palsy or other things, the basic only symptom is dysphagia and choking and bringing out by coughing after and such patients should be evaluated.
Sir, I
and a
could,
history of recent interventions.
any metastatic lymph
Yeah,
node
please.
that can also cause because of pressure. That can also be one of the causes. Acquired tracheoesophageal fistula, mediastinal lymph node.
Definitely. Malignancies are the major cause.
So that also is one.
Advanced malignancies.
Okay. Thank you, everybody, for a wonderful discussion. We were able to cover almost everything in a primary way. Now, I think I'll move on to going to the questions that we have got in our
One, I had that one liver abscess, liver. Could you?
So we
I
had
think-
covered generally the other
Okay.
topic. No, that's why I didn't want
Okay,
to
great.
go.
Fair enough. Okay.
But
Good.
it's almost reaching 9:45.
Yeah.
We'll just go to the questions now. We have a few questions up. One is Dr. Amita from Kochi in Kerala. Her question is it possible that post-viral cough lasting for more than 2 weeks could be related to gastritis? So I'll take the question first. It is actually 100% possible that can be due to gastritis, because in the viral phase, you will have, if you have consumed medicines, even simple Compiflam or any anti-flu medications, all of this will be increase the chances of GERD. And so you should be having a PPI at night for at least 10 to 14 days after the acute episode is over. And if that is not settling, then you have to definitely look for a cough variant asthma. You have to meet a pulmonologist to take it a PFT done as a reason for that cough. So any unresolved cough should be evaluated. It should not be left alone. Now, I will ask my expert panel to please add any more points if you would like to this. Or can gastritis be a main reason for the post-viral cough?
Yeah, yeah. So post-viral cough, basically not solely gastritis. They can be basically gastritis because of virus and cough because of virus. So this combination can be there. One, a causative organ affecting two organs. And secondly, as you said, Compiflam and all those anti-inflammatory drugs can cause gastritis in setting of cough.
Okay, thank you, sir. So now we have another question from Mr. A.S. Rangarajan from Tamil Nadu, Coimbatore. It's a simple question, is that what is the ideal treatment for chronic perennial rhinitis? So again, I will take it first. The number one is nasal spray. And the correlation to our topic would be, today's topic would be that the nasal spray for that disease can cause GERD and cause additional gastric symptoms. And otherwise, for the chronic perennial rhinitis, we'll have to evaluate the allergy levels and deal with the allergy from that point. Now, we have another question from Ms. Malika Varghese from Kerala. At times, my husband gets a poking feeling in his throat, especially during night time. So he gets up to sip a little bit of warm water, hence his sleep is affected. This, I would take it as if he is overweight and if he has maybe obesity underlying and with a CPAP, this OSA kind of underlying disease, I can also have some irritation in the throat. But primarily, we should consider GERD itself as the first disease to be addressed in this situation. And one very simple non-medical way of addressing it would be to reduce spicy food at night after 6 p.m. And along with that, if possible, I should tell my patients to avoid even the routine foods like chapati and maybe curries, and try to make it oats or something which is more even ragi. These kind of things help in the digestion process and will delay the gastric emptying so GERD doesn't come in very fast. So
one point, Tony, here is this typical cough which occurs little bit immediately after eating. That is one indicator which you can tell the patient, you can ask this particular point, which could sort of tell you that this could be a GERD or related cough. So that could be just a clinical indicator.
Good question. Correct, sir. And sir, also this is because it is more sleep related, is why I thought about
not in this question, in general, I said.
Yeah, sir. Correct, sir. Sir, and anybody else would want to add any point to this point of the night sleep getting affected due to dry cough? Is there anything else to be looked into? Even airway reactivity also is a factor at that point, because if the climate is also cold, especially in this cold rainy season, that is also a stimulant at night. So if it is persisting, we have to go into allergy evaluation and for even airway disease evaluation.
Obstructive sleep apnea should be for, for us, we have to consider that as one major thing here.
And I've also seen many times that what we feel as a snoring symptom that the patient presents, actually maybe a 2-week, 3-week PPI course for the night sometimes even reduces the snoring also for the patient. That is because of the chronic inflammation in the pharyngeal wall caused by the GERD. So that is also, let us say, sometimes this can mask or unmask OSA also in this way. So if usually before I even do a sleep study, I'll give a PPI for at least 2 weeks. Then only I go into a sleep study for a OSA patient. So now there's another question from Kerala again, Mrs. Sheila. I am a 65-year-old female with a reflux problem since 8 years. Acidity is there after dinner. Often gas accumulates. And she takes pantoprazole 40 milligram whenever she has the symptom. So would that be the right way to approach the symptoms she is having? So I think Abhinav sir could be taking this question.
See, this is the elderly lady with long-standing reflux, and she is only on symptomatic treatment. That is probably what I gather from this description is she is on on-demand PPI. Means whenever she has need, she takes it. But since looking at her age and looking at the duration of symptoms, she should at least, this is ideal candidate who should undergo upper GI endoscopy. Number one, to document reflux. Number two, to look for associated conditions like hiatus hernia, and number three, to look at complications like Barrett. So this is the time she should undergo thorough evaluation, including upper GI endoscopy.
Yes. So even I would feel that even diet control would be one thing.
The treatment part will come later after evaluation. That is unsaid. That goes without saying that diet control, skipping a very late night meal, skipping having dinner, elevating bedside of the head, avoiding tea, coffee, smoking, alcohol, raising the head end of the bed. All those things go without saying. But the time has come for evaluation. The symptomatology has been for 8 years now, and this is an elderly lady where she might be having Barrett's and which might be having a dysplasia.
So, Mr. Sheila, it would be ideal if you would meet a gastroenterologist who would then proceed with your upper GI endoscopy evaluation to give you the answer that do you have an ulcer or a GI related problem, or should something else be addressed if that is not coming out. So now I'll proceed to, sir, you can also take the next question where there's any role of prokinetics in the management of GERD. And
you've answered that.
Dr. Abhay, yeah, that is a mixed role. Okay. So now, Mr. S.A.S. Rangarajan has also asked that 35% of the patients don't respond to PPI. How will you proceed if the patient is H. pylori negative?
Yeah, I think that question goes to me. Whenever PPI are not working, number one, you have to look at compliance, whether we are taking drugs in a proper dose and at right time also. Only because PPIs are basically prodrug and they have to be timed at least 30 minutes before meal timing to be effective. So proper dose, proper timing, and you have to look whether the patient is compliant towards diet and lifestyle changes or not. If all those boxes are checked, then we have to go ahead for further workup. We have to revisit our diagnosis. We have to do an upper GI endoscopy considering refractory GERD, and we have to follow refractory GERD protocol, which might mandate a 24-hour ambulatory PHU. So compliance, confirming the diagnosis, and further evaluation in this case.
Yes. So then, actually, the next question is a bit different. I don't know if there is something called a psychogenic GERD. But yes, so if a patient burps when you touch any part of the body, it's a question from the audience. How would you address that?
Yeah, this is purely a psychological problem. These patients are underlying anxiety issues, and this basically this is not a burp. This is called supragastric belching. What we in common term we call it aerophagia. The anxious patient swallows air which doesn't cross alias, and from esophagus itself it is burped out. So this is supragastric belching, which is a feature of underlying anxiety disorder. Here, whatever you may give, you give PPI, you give prokinetics, patient is not going to respond. Patient is going to respond only once we address his or her anxiety with the anxiolytic medication. And I have used her here because this is more common in females.
Tony, just on this little... not a joke, seriously, these people sometimes come with this tension headache and they say that they feel better after they burp. No, I can't understand how a tension headache is related to, but
This is
they
a
keep
conversion
on
phenomenon.
same
This is a
complaint.
conversion phenomenon.
Many people come with same.
Yeah.
सर में बहुत दर्द होता है, but शक्कर के गैस निकल जाएगा तो सर, then you feel better, right? So again, as doctor, it's a total psychological link which is caused. The headache itself is because of tension, and somehow they have related it to the GI system.
There is one concept also, gut, lung, brain axis also. So there is some concept of gut, lung, brain axis also. No, it is there, sir. I am not joking.
This thing and migraine to have a very
Correct.
good connection.
So there is gut, lung, brain axis also.
The migraine, okay, I can understand, but here they are just non-specific. This is just a headache. Not a CT scan, this, that, but just headache, they are feeling better when they burp. I mean, that is, sometimes I just say, you go to gastroenterologist.
Sir, when the patient came back, what they said? How was the...
No, I have not, they have not come back to me. I don't want to get in. But it's this kind of, many patients have said this. This headache and related to getting relieved by a GI, this thing burping. That's why I thought I would just tell you when this talk of this.
Right, so because you will think that this is more of a psychological thing, but actually what you're saying is probably that yes, they should be evaluated without thinking of it with just a psychological evaluation.
Just say that way.
Yes.
I think he wants to say something.
Yes, sir. And sir,
I want to highlight by Abhinav Sharma, sir, what is the role of mebeverine and chlordiazepoxide? I see a lot of patients for PPIs also taking these drugs. Can you just give pointers, just 2-3?
Mebeverine actually is an antispasmodic drug, and this combination is used in patients of IBS who have pain due to small bowel spasm. Since IBS patients have anxiety and psychological overlap also, hence chlordiazepoxide is added with this in this combination.
Thank you.
Yeah, thank you, sir.
Sir, and Dr. Abhay Singh from Rajasthan, Jodhpur. Yeah, we have already covered the question about the relapse of H. pylori infection, which, yes, as Sarah said, we have to again reevaluate and continue treating the problem. But, sir, one thing is, how can one prevent H. pylori infection? So, yeah. Abhinav, sir, how would you take that?
So, H. pylori is basically by fecal-oral route. The prevention is same as we prevent food poisoning, as we prevent other waterborne and foodborne diseases. We have to maintain our hand hygiene. We have to avoid eating at unhygienic places, and that is the only way to prevent H. pylori. And I can see here duration of anti-H. pylori therapy in case of reinfection. So first, we have already discussed, we have to prove whether it is reinfection or it is a resistant infection which has not been cured. In both of the situations, especially in refractory ones, the PPI regime should consist of 4 drugs, and at least 2 drugs should be newer one, and duration has to be not less than 14 days.
Thank you, sir. Yeah. And sir, now one mixed question is there. I will not be able to take every question because we're running out of time. So I'm going to ask one question from S. Jairam from Tamil Nadu. They have an elderly patient who is having vomiting, and of course, with that aspiration or microaspiration is happening. How to manage whether it requires any PEG or any long-term RT? How I would address that question would be that we have to look at what is the cause for the vomiting. Without understanding the cause, we cannot address what kind of treatment is required. If malignancy underlying or medication-wise issues, or for example, that if there is a malignancy obstruction in the throat or there is a swelling, patient is post-tracheostomy, something like that, then it's better to go for a PEG if it is going to be long-term, because you can avoid the RT route. As a disturbance, the face will become free for the patient. So they also feel a bit normal in that way without having a tube coming out from the nose. That is if you have a long-term, and PEG can always be closed also in the future once the primary cause has been addressed. But now if it is a short-term vomiting issue, and then we don't need this kind of things, we have to basically go for a Prokinetics and PPI and see how it responds to that. And if it is again recurring, then only you go into this kind of thing. But every patient who comes back with a repeat chest infection in a very frequent, in a more than average frequency, we should consider microaspiration and consider maybe the feeding is having, there's a mistake at home. Maybe it's a patient we have intubated, we have treated, we have put an NG tube and sent home. The housemaid must have changed who is feeding, and they must have done something to dislodge the tube. So reassessment of the tube placement is an important thing, which can be resolved with a simple chest X-ray. And that should be a basic primary thing to check before we escalate treatment to long-term or into PEG for addressing that issue. Now, anybody would like to add to that point, please? Vishnu sir, or Abhinav sir.
Here, if we are suspecting microaspiration, then rice tube should not be placed. Sorry, because rice tube promotes GERD. It is a bridge between stomach and esophagus, traversing LES, and it through siphoning effect increases microaspiration. So if we are suspecting microaspiration, go for PEG rather than rice tube. So that's what I wanted to add.
Sir, Vishnu Sharma sir, Tridib sir, from our pulmonology point.
There's what? No, I think I would not be able to add anything in this.
Okay, sir.
Dr. Jayaraman asked a very interesting question about esophageal manometry. I think that one, if you could just, because that is concerning us and where we would like the gastroenterologist's opinion. Esophageal manometry is an invaluable tool for diagnosis of sleep disorder, especially the upper syndromes. So, I mean, I've never heard of this being upper respiratory syndrome, but manometry being useful. So, can anybody?
Yeah, here I think what he's referring to is a cricopharyngeal spasm, which presents with dysphagia rather than upper way issues. So manometry is basically motility study, assessing the motility of esophagus and LES pressures. And newer manometry catheter, which are available nowadays with more number of ports and high resolution manometry, we are able to map upper esophageal sphincter also, and we can diagnose upper esophageal sphincter pressures and problems like cricopharyngeal spasm. So these patients usually have dysphagia before aspiration.
And sir, there's another question which you can take. Levosulfide causes drug-induced Parkinsonism. How would you comment on that?
So this is very common because I never write a combination of PPI with levosulfide, because once you write that kind of prescription and patient is symptomatic, if he's better, so he doesn't come for follow-up, or he and she, they continue to take on these combination for long term. And yes, it doesn't cause Parkinsonism, but it is said that it unmasks the latent Parkinsonism. So once Parkinsonism occurs, it is permanent, and patient thinks that this Parkinsonism is because of levosulfide. So in elderly patient, it should not be prescribed. For long term, it should not be prescribed. If it is to be prescribed, it is to be given for short term in younger patient and separate from PPI.
Thank you, sir. And sir, now I would like to come to probably to a conclusion of our discussion today. So we are almost touching 10 o'clock. And Tridib sir, as we all, the past 1 week, we all have been very, very busy reading up and revising all the theory parts. And sir, you had shared to us earlier that you had found a unique article where a pulmonology drug is going to proceed into.
I found one very interesting article that in Perfenadone, which we are using for fibrosing ILDs and progressive PPF and all that, they have tried in experimental rats, and they have found that this could be a useful thing in preventing liver fibrosis, which is what happens in the cirrhosis, and then the portal hypertension. Then you are doing all this fibro scan, which our guest, Dr. Abhinav Sharma told us all details about. So they have said that maybe in some status stage, Perfenadone, in addition to the lung, might help in also reversing fibrosis in the liver. So of course it was only in on experimental animal models. So it's not yet been done on human beings. It's just an interesting thing I found.
Yes, it was very new to hear. I've also not heard of that.
Yeah, I was just going through this article and I just Just then it's a very small article, but it is just specifically mentioned it's only with rats. So it's not done on humans at all. So
Yes.
maybe sometime in the future.
Sir, I would like everyone, I'll be thanking every one of our panelists, and I would like each of you to give a take-home message of, as a conclusion of our talk, what our audience should take home as a learning. So I will start with our guest speaker, Dr. Abhinav Sharma, sir. Sir, could you please give a small message?
So my take-home message will be based on my talk. So number one, if a patient with cirrhosis or portal hypertension develops breathlessness, always consider hepatic hydrothorax first. Get in chest X-ray. If effusion there, it is hepatic hydrothorax, whether ascites is there or not. Then, if there is no effusion on X-ray, then we have to consider two possibilities: hepatopulmonary syndrome and portopulmonary hypertension. We should proceed accordingly, provided we have ruled out common causes like pneumonia, like ILD, like simple anemia. All those causes have been ruled out. So this is as far as first part of my talk is concerned. In second part, GERD and lung interaction, we should suspect is GERD on the basis of symptoms. If atypical symptoms are there, then typical GERD symptom like heartburn will not be there. So here we have to be more suspicious, and here we should have low threshold to document GERD by means of upper GI endoscopy. And if upper GI endoscopy is negative, which may happen in 50% case of GERD, then we should be going in for pH metry if we are suspecting GERD. This is my take-home message.
Thank you very much, sir. And I'll ask Dr. Him, could you please give me what is your outline of the entire program today? What you give home?
Sir, I would like to say two practical points. One is chronic oral theophylline use causes the nausea and vomiting. So be assured if the prescription contains deriphylline, doxophylline since years. Second, in IPF and GERD, it is proven role. So have high suspicious of index if the IPF patient is there in your clinic and you evaluate for the GERD.
Thank you. And Dr. Tridib, sir?
Yeah, so my just take-home opinion is that when, see, as a pulmonologist, patients come mainly with cough and dyspnea. So in addition to a respiratory, we just start thinking whether he's got pneumonia or asthma. So we should also think of the GI system, the GERD, because of drugs, because of food habits, whatever. So that can be the cause of cough that you have to think of. And also, if the patient is already established ILD case or obstructive airway disease, remember, controlling GERD, controlling the aspiration, controlling this can be a very major step in preventing the worsening of the disease rather than in just increasing antifibrotics and more inhalers. Same way with sleep apnea. So that is the thing which GI system and gastro have to be closely linked with the pulmonary system. Thank you.
Thank you, sir. Vishnu Sharma, sir?
Yeah, sometimes as organ specialists, we tend to look at only the organs that we treat. But we should always see the patient as a whole. A lot of patients with the respiratory symptoms can have additional GI problems. Or sometimes, the patients with GI problems can present with the respiratory symptoms. So we should always evaluate the root cause for the symptoms and then treat accordingly.
Thank you, sir. And so I would like to give all of our panelists our special thanks to our founder and trustee members, Dr. Krishna sir and Dr. Narayana sir, for arranging this entire webinar series. And our National President, Dr. Ashish Dubey sir, and Dr. Anil Maske, our National Secretary. It's the heartfelt thanks. Thank you for letting us conduct this program. And our backend team, our CCI webinar core team, Dr. Ravi Dosi, Dr. Atri, Dr. Vijay Chanam Shetty, Dr. Kirat, Dr. Shivani Swami, and from Cipla, Mr. Vipul. Thank you for doing all the needful we needed for conducting a beautiful webinar. And I hope we'll get back to this again.
Thank you. Thanks to CCI. Thanks to all my colleagues. Thank you. Thank you, Tony.